Thank you, welcome, Mr. Robichaud, and I'd like also welcome to our witnesses appearing virtually. My first question is for you, Mr. Robichaud. It is about disaggregated data, which you brought up at the beginning of your speech. You noted that this lets you paint a portrait of the health status of the population, but you don't necessarily have all the information. And what information you do have is not necessarily disaggregated. Could you please talk a little bit about what advantage this would even have for the government? What advantage would it have not to accumulate that level of data and to not disaggregate it? Well, that's hard to answer. But I just want to build on what I brought up earlier. When you look at the health system, you see how things have evolved and how we've managed to make things work without disaggregated data. We shouldn't point only at the government in power. Our whole system has evolved around disaggregated data. And it's not that things were disaggregated data were missing. It's that it was spotty. So we needed more resources, for example, to understand local health. And there weren't always resources on the ground to allow for this, especially in resource-strapped regions. So it wasn't necessarily a political decision. It was an organizational or logistical decision. One thing I've learned through my experience is that this is a reality in the public sector, not just in health. The same could be said for the educational system, the social system. All of these systems would benefit from a better understanding and of the population during the decision-making process. Thank you. It's strange because earlier we were examining Bill C-11, which brought up algorithms which generate just so much information. And yet, in health, imagine what we could do with tools like that create information. And despite everything the health system has, we don't have our hands on the right data. It's not what we're investing in. This is a shame, is it not? Won't this have a negative impact on services? And given this, what is being done? I'd like to build on what you brought up earlier. I think the use of algorithms and new technology in data management, well, there's potential there. But when you think of these algorithm companies, the reason they use the tools they use is to meet their own specific needs. Meanwhile, in the public sector, as they say in English, garbage in, garbage out. So it's no use gathering data that is of poor quality. Over our experience, we learned about some nuances of geographically disaggregated data. Certainly, it's important to break things down by postal code. But there's a lot of noise in that data as well, so it doesn't properly represent the needs of people. Another point. Just regarding resources, we don't really understand the resources we have in the health sector. Human resources, family doctors. We don't necessarily know what we have and how they're being used. I was struck by one incident at the beginning of the pandemic where I was asking questions about respirators, and no one was able to answer questions like how many respirators do we have in the system. we aren't able to answer the right questions because we don't track our resources very well. There is data on resources as well, but when our council gets an answer to a question, we need to verify it because we cannot trust the first answer we get. So if we were to rely on simple algorithms, we would get poor quality data that would not be reliable. If we try to use data better, if you build it, they will come. So the data quality will improve as well.